Good morning, AAIP members. Welcome to our webinar on our video presentations. Today we're going to be talking about the doctor presentation. We have already covered the new patient phone call, the doctor call, when the patient arrives, and now we're going to be talking about the doctor presentation. Now, when you guys watched the video the last time, it was when the patient has arrived to the office and the assistant takes the patient back and we do our data collection, we do our brief, and then the doctor comes in and continues the examination. So today we're going to go over the video of that doctor presentation. Before we do that, just to let you guys know a few things that we have going on. One, we are going to be coming out with and sending out the schedule for 2017 soon so that you guys can have the dates for that. Also, Dr. Sheldon and I will be speaking at the Seattle Study Club in January 25th in Orlando. So if you're going to be there, please come by and say hello. We'd love to see you. Also, we were recently running a special for new members. We are willing and we would like to extend that special. So if you know somebody that has been thinking about becoming a member, please refer them over, because for you guys we do 3 months of free membership if you do refer someone over. So take advantage of that. Do you have anything else to mention before we get started?
I have nothing.
No?
Nothing at all. I wish I had. Am I supposed to say something?
I don't think so.
All right, good.
Just checking.
So let's talk about the doctor presentation. The doctor presentation is important, but what's more important, I'm glad there's some staff members on the line today, is to understand what the doctor is supposed to do, or what the doctor has to do, and really what the staff member has to do in order to be able to allow the patient to gain confidence in the diagnosis and the treatment plan, and then what the financial assistant can do to carry that ball to fruition, which means treatment acceptance. So we're going to, just like we did last month, we're going to play this all the way through once. It's only about a 5-minute video. And then we'll go back and play it once again, and we'll stop it at what we think are critical points so that you can go over it again. And then you'll have this all as a recording, professionally done by the end of the month when you receive your discs.
Let's take a look at the X-rays and see what's going on. Okay?
All right.
Good. All right, Joyce, so let's take a look at this in cross-section and see how it looks. So let's take a look at a regular CT scan first. And you can see here's the area where the tooth is missing. And now we're looking at this in cross-section. So this is the cheek part of the bone. This is the tongue part of the bone. We can measure the bone. We can actually see how much bone we have available. And you've got a lot of bone available, 17 millimeters. We don't even have a dental implant that's that long.
Oh, great.
Yeah. And if we look at the width, you know, minimum width we need is about 5.5 millimeters. You've got 10.5 millimeters. It's really good.
Oh, good.
So let's take a look back in a mode where you can see it a little bit better. And let's actually do the implant surgery right on the screen, okay?
Oh, that's amazing.
Good. Let's do it. So you put the implant right in there. And you can see here's the implant. It fits right in within the bone.
So does that mean I would need to have a bone graft?
Look at it, you've got a lot of bone there. No bone
Okay.
graft.
That's great.
So let's get that lined up so that it's fitting perfectly against the upper tooth. Now let's put a crown on it. We can reduce the height of it so it fits in just perfectly. What do you think?
Okay. That's wonderful.
That's good.
I would love to have that.
Good. Let's take a look.
Okay.
All right, Joyce, so the bone is healed in very well. Things are in good shape. There's really two options you have here. One would be a fixed bridge, the other one would be a dental implant. In a fixed bridge, we'd have to grind down the teeth on either side of the space, and then you'd have a 3-tooth bridge, something that's secured to those 2 teeth, that would have a replacement tooth in the middle.
Okay.
Now, neither of the other teeth have been touched, so, you know, each time you take a dental drill to a tooth, it does damage to the tooth.
Right.
So the other option, of course, is the dental implant that we talked about on screen. And what we do there would be to do a little incision, place a little post in, and a few months later you would have a crown that we put in place, just like we saw, as I said, on the screen. Now, there is a little bit of gum tissue missing, and so I'm going to have to do a soft tissue graft to replace the gum tissue that's missing. So what I'm going to do is describe that a little bit to Danielle, and then Danielle will talk to you about that in a lot more detail.
Okay.
Okay? So Danielle, what we're going to do is we're going to do a subepithelially connected tissue graft in the area of number 19. I think we can do that in conjunction with dental implants. So we should be able to get it all done in one visit. I'll probably need 4 units for the graft and probably 2 units for the dental implant.
Okay.
Okay. We'll put a helium abutment in on that day, and then we'll do an ostel check in about 3 months, and then Joy should be ready to have her crown.
Okay. How important is it that she get that soft tissue graft done? Is it cosmetic option or?
It's not really a cosmetic option. The tissue isn't firm there at all, and so she's going to have some irritation when she brushes her teeth if we don't do the soft tissue graft.
Okay, got it. All right, do you need any materials for that?
I'd like PRGF.
Okay.
We'll probably use just a little bit of mineros because there's a little bit of a deficiency in the bone.
Okay.
We'll decide that at the time of the procedure.
All right. And what
And
about
then I'd like a palatal stent because
Okay.
we're going to be using a subepithelial graft.
of her palatal stent?
Yeah.
Okay.
Yeah.
Does she have to use her own tissue? Can we use packaged tissue?
No, we can use packaged tissue. We can use perioderm. That'd be okay.
Okay.
I think, for a tissue match type of thing, we'll do a little bit better.
Okay.
But it's not going to show in that area anyway, so a perioderm graft would be fine.
What about for the implant area? Do you want an Essex or anything to fill that area, or just
Yeah, I'd
leave
like
it?
an Essex. She just had the tooth removed. I don't want the teeth to drift in place. And
Okay.
so if she just wears that Essex 2 hours a day, that should be enough.
All right. And how long does she have to wait until she gets that crown on that implant?
I'm figuring it'll be 3 months, maybe 4 months. It depends upon what we find at the time of surgery.
Okay. All right. And is there any other options besides the bridge and the implant? Does she have removable options?
Well, she could have a temporary or a removable partial denture. I call it a temporary removable partial denture because it's really going to be temporary. It's something that she won't be able to chew on very well. It'll be there. It'll replace it cosmetically, but
Okay.
that's about it.
Okay. All right. I think I have what I need.
Very
Did
good.
you have any questions, Joy?
No, I will have some for you, I believe.
Okay.
The PRGF you mentioned.
Yes.
So,
We
Yeah.
can go over all that.
okay. Sounds good. Thank you.
Good. You're welcome.
Okay, so let's go over some of the principles here. Number one, what you didn't see was the examination part of it. We just cut the tape there. So certainly there was the examination part of it. And the examination is important. The examination essentially is a continuation of all the communication skills that we've taught in the past. It's essentially allowing the patient to participate in the examination. And I'm going to give you some examples there because it wasn't covered in this film. There is a great thing that we can do for a periodontal examination. Many of you do it. And that is to say, I'm going to be doing a periodontal probing examination. This is to measure and determine how whether you have a periodontal disease problem. If you hear the numbers 1, 2, and 3, that's good. If you hear more than that, then you probably have some periodontal disease. Okay, so now rather than the patient just hearing a lot of numbers, now the patient can key in on 4, 5, 7 and know that in fact there's some periodontal disease present. And so you're always advising what you're going to do, not just to warn the patient, but to educate the patient so the patient can look for that. You can do the same thing with recession. We're going to go over recession now. Ordinarily we'd be seeing zeros here, so anything more than 0, it means you've lost some bone support too. So, and that way if they hear a 0, 2, 3 or whatever it is, then of course their ears perk up and they want to know what in fact is wrong and does something need to be done about it. The other thing is that we want to make sure that the dental assistant is there not just to record, we want the dental assistant there to participate. Patients are embarrassed to ask you questions because they think they're going to sound dumb. Well, if the assistant asks the question that the patient was already thinking of, wow, it saved the the patient some embarrassment, and the patient gets the question answered. And you know patients are asking the same thing every time. You know what some of those questions are. And so that if your assistant is actively participating in the examination, you're helping that patient. That patient is becoming more knowledgeable as the examination goes on. You know, in sales, there's a lot made about the close. You know, the close. You know, how do you close it? How do you close it? You know, the close is a natural progression from everything else, and a close should come easily with the patient being educated and the patient coming to the natural conclusion that, in fact, treatment is the only option, or treatment is the best option. The close occurs with everything we do, and I'm talking about assistance, I'm talking about front desk, answering the phone, all of the things that we've done up to now. You know, those of you who are new, and we got quite a few new members as a result of the special. Thank you and welcome. Everything that occurs from the moment the patient calls your office to the time the patient arrives is all a build-up. Think of it as a symphony. You know, you're building up until that crescendo hits, and finally you get to that climax where the patient says, okay, I'm ready to get treatment done. All of this is orchestrated and has to be orchestrated with a very well-trained staff, and that's what we're doing. That's why you're all here, and that's why you're attending these and listening to these CDs and DVDs.
Well, also, this whole thing starts with the relationship building, and I think we've beat that so much in this program, where what we can't make a video of is how to do that relationship building, because it comes from the heart. And when I'm working with my girls and we are talking about strengthening this every single week, it's habit for us, and it can become habit with your staff as well. But it's really enjoying the patient, it's really getting to know the patient, and it's really getting that bond with the patient, because what we find is when these patients come in, especially the ones direct from off the street, they have these walls up, and they are embarrassed, and they think they're the worst case that you've ever seen, and they think that their mouth is the worst that you've ever come across, and they're either embarrassed on how it's become this bad, or they feel like you're going to take their money, you're going to misdiagnose them, or you're going to overdiagnose them, whatever it is. They have that, and your staff can break down that wall. We can break down that wall in 10 minutes, and you can do it while you're taking X-rays, and you can do it while you're getting all the data collection. But what I'm looking for during that time, and you can do this if your assistant is the one going all the way to the case presentation, or if you have the FA staff member come in, because you're still going to keep that assistant in the room. And what they do is, as they're collecting the data and they're talking about what is that you want, what is it that's most important to you, what is it that you want to see when you're all done, and you're finding out what they're really wanting. You can find out how they got there. You can find out what they don't want to hear, what they would not accept, what really is going to help them accept treatment. So as I'm talking to these patients in the room, I will find out a story. For example, I went to go see somebody a few weeks ago about this, and I decided to get a second opinion because the guy said I needed 2 implants, and I don't think I need 2 implants. I think that area needs 1 implant. So I'm really curious to see what your doctor says, because, you know, I just think it's ridiculous. I just think they're just trying to, you know, sell me more implants. And so with that kind of information, when I go do the doctor brief, I'm going to say, she's already had an examination in another office. They think she needs 2 implants. It's a really touchy subject with her. She really thinks she only needs 1, so that Dr. Sheldon will understand my question when it comes up. Or if they say something like, I will not do a denture, or something where I will not do implants, or whatever it is, because I'm creating that relationship with them, we get that bond. They start to trust me in my opinion and what I've seen. I share stories with them, personal stories, stories of other cases, and they really start to tell me things that will be very important when Dr. Sheldon starts giving me the plans, and I can start asking him questions in front of the patient on the patient's behalf, and they can understand why he's saying what he's saying.
So let's go through this video again, and we're going to break it important points, or points that we think are important, so that you have kind of a running commentary on what we'd be doing during the examination process.
Let's take a look at the X-rays and see what's going on. Okay?
All right.
Good. All right, Joyce, so let's take a look at this in cross-section and see how it looks. So let's take a look at a regular CT scan first. And you can see here's the area where the tooth is missing. And now we're looking at this in cross-section. So this is the cheek part of the bone. This is the tongue part of the bone. We can measure the bone. We can actually see how much bone we have available. And you've got a lot of bone available, 17 millimeters. We don't even have a dental implant that's that long.
Oh, great.
Yeah.
So let's take a look at that there, and let's just look at the operatory setup. So notice I'm sitting at the screen, and I'm working at the screen, and Joy actually is looking at that screen right now. But Joy has every option to look at a much bigger screen right in front of her. The bigger, the better. You know, these are monitors. These are monitors you can pick up at any store, any place, and these monitors allow the patient to see not only the X-rays, but we talked about in the past photographs. How much more effective is it for a patient to see a big blown up photograph of his or her smile? And so I really think that the size of the monitor makes a difference. This is actually one of the smaller monitors we have in the office. This one, I believe, is a 34-inch, and I think the rest of them are 40-inch monitors. So we want to make sure that that's there and that it's easy for the patient to see. The other thing that you'll notice is the technology. And for those of you who don't have CT scans and don't want to invest in a CT scan, that's fine. But certainly if you're going to have an outside provider do the CT scan, you still need this same setup or set up similar to that so the patient can see exactly what you're seeing, and so that you can be educating the patient on exactly what is going on what is obviously a very simple case.
And if we look at the width, minimum width we need is about 5.5 millimeters. You've got 10.5 millimeters. That's really good.
Oh, good.
So let's take a look back in a mode where you can see it a little bit better. And let's actually do the implant surgery right on the screen, okay?
Oh, that's amazing.
Good, let's do it. So you put the implant right in there. And you can see here's the implant. It fits right in within the bone.
So does that mean I would need to have a bone graft?
Look at it, you've got a lot of bone there. No bone
Okay.
graft.
That's great.
So let's get that lined up so that it's fitting perfectly against the upper tooth. Now let's put a crown on it. We can reduce the height of it so it fits in just perfectly. What do you think?
Okay. That's wonderful.
So when we look at this, when we look at how this technology makes a big difference, I've got to tell you that when we bought this software, and this is the Anatomage software, it so totally revolutionized the way I was doing my case presentation. We think when we look at X-rays and CT scans, really impressive. We can see the bone in 3 dimensions. It looks like a black and white X-ray to them. But once you put in this kind of software, which really isn't all that expensive, all of a sudden now the patient can see a jaw, can see teeth. It makes sense. And you could see what we could do with it. We always talk about the fact that we'll do the surgery on the computer before we ever do the surgery in the mouth. And that's what you saw here. And not just the surgery, not just putting in the implant. The patient doesn't care about the implant. The patient wants the tooth and can see the tooth and sees us adjusting the tooth so the tooth fits in to the arch properly.
Yep.
I would love to have that.
Good. Let's take a look.
Okay.
All right, Joyce. So the bone is healed in very well.
So it's very important at this point. Like I said, some of you may have your dental assistant do the examination with you and do the financial with the patient both, which is fine. Some of you may have a separate FA assistant than the dental assistant. That's fine too. But the dental assistant must stay in the room while the FA assistant's in there because remember, the relationship has initially been made with the dental assistant and the patient. So now with the FA assistant in there, we've got to bond that in together. So for us, usually the FA assistant is the dental assistant, so I can do the whole thing. But either way, you can do it, and she knows, the dental assistant knows to ask questions on behalf of the patient, and then we all work together in there. So it's very important, if you do have a separate FA assistant, make sure they're in there before you present or start talking about what the plan's going to be.
If you don't know our lingo, FA means financial
Yes.
arrangements.
In good shape. There's really two options you have here. One would be a fixed bridge, the other one would be a dental implant. In a fixed bridge, we'd have to grind down the teeth on either side of the space, and then you'd have a 3-tooth bridge, something that's secured to those 2 teeth that would have a replacement tooth in the middle.
Now understand, this was paved pretty well for me, because when the dental assistant is doing the initial prep on the patient before I ever walk into the operatory, the dental assistant has already gone over these options, has already educated the patient with regard to a dental implant or a fixed bridge with models, and so that the patient has a good idea as to what I'm talking about. It allows me to give an overview only, and that's all I need to do. I have to be the doctor. I don't have to be the salesperson. I'm the doctor. The doctor essentially is the one who says, this is your diagnosis, this is your treatment plan. And so I'm explaining it as an overview, relying upon the financial arrangements assistant to then explain it in more detail, what exactly is going to happen. So there are times when the less time I spend in the operatory, the better. I guess there are times when there's sometimes when it's good for me to spend more time in the operatory.
Yeah, and you'll be able to sense that patient. You'll be able to sense the patient's okay with what you say. They're completely fine with the plan. They don't have very many questions. Fine, don't oversell. Get out of the room, and then we'll do the rest. And there are times when they keep asking questions. I answer the questions. You may be in there extra long, but if they're a patient that really needs that from you, then give that to them, because if they're not going to get it from you, they're going to find somewhere else to go. They're not going to feel comfortable. So sometimes we do sense that patient, and he stays in there. We stay in there until when he asks, do you have any more questions? They say no, they're fine.
At the same time, if there are procedural questions, if it's how much is it going to cost, what kind of pain am I going to be in, that type of thing, assistants, we doctors are trying to get out of the operatory. We are. And it's so important that you say to the patient, Joy, I can answer those questions for you.
Not the doctor.
And that way it gives me the opportunity to leave.
If the doctor says, well, Danielle will answer those for you, it sounds like he's trying to get out. But if we pipe up and say, you know what, you and I can go over all that, I can help you with that, then they say, okay, all right. Also, it helps when you say, Danielle has been with me for a long time. Danielle knows what's going on. She can answer all your questions, and if she can't answer them, she knows where to come find me. So that also helps there.
Okay.
Now, neither of the other teeth have been touched, so each time you take a dental drill to a tooth, it does damage to the tooth.
Right.
So the other option, of course, is the dental implant that we talked about on screen. And what we do there would be to do a little incision, place a little post in, and a few months later you would have a crown that we put in place, just like we saw, as I said, on the screen. Now, there is a little bit of gum tissue missing, and so I'm going to have to do a soft tissue graft to replace the gum tissue that's missing. So what I'm going to do is describe that a little bit to Danielle, and then Danielle will talk to you about that in a lot more detail.
Okay.
Okay?
One thing here is I let him go on ahead and give his presentation to the patient here without interrupting him. I let him give kind of the options and an overview of what he's seen, so that they can talk, and I'm not cutting in and disturbing that. What I'm writing down more than anything at this time is what I'm going to ask him, because I know what she's thinking when he's telling her these options, so I don't want to forget to ask those questions. So that's a lot of what I'm writing down here.
So Danielle, what we're going to do is we're going to do a subepithelially connected tissue graft in the area of number 19. I think we can do that in conjunction with dental implant. So we should be able to get it all done in one visit. I'll probably need 4 units for the graft and probably 2 units for the dental implant.
Okay.
Okay. We'll put a helium abutment in on that day, and then we'll do an osteo check in about 3 months, and then Joy should be ready to have her crown.
Okay. How important is it that she get that soft tissue graft done? Is it cosmetic option or?
It's not really a cosmetic option. The tissue isn't firm there at all, and so she's going to have some irritation when she brushes her teeth if we don't do the soft tissue graft.
Okay, got it. All right, do you need any materials for that?
I'd like PRGF.
Okay.
We'll probably use just a little bit of minerals because there's a little bit of a deficiency in the bone.
Okay.
We'll decide that at the time of the procedure.
All right. And what
And
about
then I'd like a palatal stent because
Okay.
we're going to be using a subepithelial graft.
of her palatal stent?
Yeah.
Okay.
Yeah.
Does she have to use her own tissue? Can we use packaged tissue?
No, we can use packaged tissue. We can use perioderm. That'd be okay.
Okay.
I think, for a tissue match type of thing, we'll do a little bit better.
Okay.
But it's not going to show in that area anyway, so a perioderm graft will be fine.
What about for the implant area? Do you want an Essex or anything to fill that area? Or
Yeah,
just
I'd
leave
like
it?
an Essex. She just had the tooth removed. I don't want the teeth to drift in place. And
Okay.
so if she just wears that Essex 2 hours a day, that should be enough.
All right. And how long does she have to wait until she gets that crown on that implant?
I'm figuring it'll be 3 months, maybe 4 months. It depends upon what we find at the time of surgery.
Okay. All right. And is there any other options besides the bridge and the implant? Does she have removable options?
Well, she could have a temporary or a removable partial denture. I call it a temporary removable partial denture because it's really going to be temporary. It's something that she won't be able to chew on very well. It'll be there. It'll replace it cosmetically, but
Okay.
that's about it.
Okay. All right. I think.
All right, so as we said before, for a lot of the questions that I'm asking, I already know the answers to them. I want her to hear the answers. So I may ask him questions like, why are the teeth so mobile? Or I may ask him questions like, can you do the 1 implant versus the 2 implants? Things like, are there removable options? It's the answer is what I need her to hear. I need her to hear that yes, there is a removable option that's going to be a whole lot cheaper, but it's not ideal because of whatever. So it's things that I need to have in my back pocket when I go to financial, because the worst thing you can do is just have one option, because they feel kind of trapped with that one option. It may be the best option, but they need to hear other options to decide for themselves that they want that best option. So when we're doing that, I do ask questions on the patient's behalf. At this time, I may know exactly what the patient's concerns are, and I want to be sure I get that out. I also don't want to go into the financial room and close the door and have the patient ask me some questions, and I have to go out or not have the answers, which is going to really affect my acceptance. So I want to go in there with them knowing I have all the answers and they've heard it all from Dr. Sheldon. We gave a bridge option, we gave an implant option, and we gave a partial option. So we gave 3 options here that we're going to talk about and go over in that room. Now this is a very simple case. We don't deal with simple cases like this every day. Some of the cases are pretty big, and I know I'm going to have to present a plan where I'm asking for $27,000, $35,000 from a patient. So I want to know, how about a denture? Is a snap denture an option? Different things that when I go in there, I can show the patient, so that when it comes to a $27,000 plan or a $2,000 denture, I can show them and I can explain everything. And I know for a fact that it's an option, because sometimes I'll ask you if a snap's an option and you'll say absolutely not. And sometimes we try to get you to do a snap option and you say absolutely not, because I'm working for the patient here at this point, trying to get them accepted, trying to get them an answer, trying to get them some help. But we do talk about that in the room. You'll say, no, I will not do a snap because it's not going to last very long. So that's what we're doing here, is I'm making sure that I have all that.
I want you to see something here that's important. It's important for you doctors, and it's important for staff as well. And it's something that we've been talking about for many, many years. And that is, whose patient is this? And the answer is, it's the assistant's patient.
It's my patient.
Isn't that awful? We went and trained for blah, 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 and residency, blah, blah. It's the assistant's patient. Assistants, you should know everything that I'm doing and everything that I'm going to say. Assistants, you need to know exactly what the treatment plan is and why. Doctors, you have to let your assistants rise to that level.
Compliment them. Talk about how qualified they are, how good they are, because unless you are going to present that plan to them, you have to allow them to have that what do you call that ability, so
But that elevation, that status or stature, if you will, that in fact, Danielle really, I mean, she's the top assistant. She just is. Laura is the top assistant. She just is. Jennifer's the top assistant. She just is. Courtney's the top assistant. Everybody's the top assistant. And these are highly trained individuals. And what that means is you can get in the operatory, do the work that you need to do, and do the examination that you need to do, and you're leaving it to your highly trained staff to explain everything. And that allows me to get in and out of the operatory, usually in less than 30 minutes, sometimes sometimes 20 minutes. So this is a matter of orientation. And frankly, this is a matter of communication, and frankly, also, this is a matter of trust. The trust occurs when the education occurs and the staff member says, oh, I can do this, I can feel this. Danielle started as my surgical assistant. She didn't rise to office manager just because she knew how to pass instruments real well. And one of the reasons all of this occurred and why now Danielle is on a national stage is only because I said, you can do it. And she said, okay, I guess I can.
That's true.
And then she pushed.
That's
and
true.
she did it. And when she did that, I wasn't satisfied and said, you can do this. It's a matter of allowing your staff members to grow as much as they can, because if they do, your practice is going to grow as well. And frankly, patients are going to be so impressed by your practice that they're going to want to bring other patients or refer other family and friends to you, simply because of the competence of you, but as importantly, and maybe even more importantly, the competence of your staff.
I'm going to say that that's probably the most valuable thing I've ever heard on the AAIP because it's true. One reason why you have such key and valuable staff members is because you do take the time to make us feel that way. If you make them feel like they can do it, they will do it, and they're going to want to do it even better because they're going to want to keep getting that feeling and that trust from you. I've worked with so many offices that don't get that from their doctors because the doctors are afraid that the staff is going to lose the sale or not be able to do it right, and they try to do everything themselves, or they don't give that confidence. They don't express that with their patients. So the patient looks at them as a measly little old dental assistant. They don't do that in this office. I mean, there's times, Dr. Sheldon, that you and I will be in a room, and I'll suggest a plan that you haven't even mentioned. I will recommend something, and sometimes it's a pretty good idea, and sometimes we'll even go with it.
And it's okay. That's right. And sometimes we will go with it, and it doesn't mean that, boy, assistant was telling the doctor what to do? What's that all? Frankly, there are a lot of good ideas, and I'm going to tell you, there have been times the patients have also told me, what about if we did this? And I said, gee, that's a good idea. Now, if it's not a good idea, that doesn't mean you put the person down, and I know none of you would ever do that, but you don't put the person down. You explain why that's a good idea or why that's not a good idea. Number one, the patient's hearing, the patient's becoming educated. The staff member had the guts to say something, and so you want to enforce the guts, and frankly, we should be able to explain it well enough to allow both the staff member and the patient to understand why it may not be a good idea in logical terms and in real English, not dental English.
Right. And I get real close with my patients, and I follow them throughout treatment and even after treatment is finished. And I will tell you that many of these patients, almost all these patients, are so impressed with that relationship that he and I have together, or he and his other assistants have together, because they feel like we are so qualified and so knowledgeable, and they love that. I mean, there are times that he says, and he's right, he doesn't shoot me down. He won't say, no, we can't do that. He'll say, we could do that, but look at this here. If we do that, then this will happen, and then this, and the patient and I both go, oh, okay, well, at least we're spending the extra time to go over possibilities. And they see that we're working so well together, and we have that trust, we have that bond, and we've been working together for a long time doing this. It speaks volumes for you, volumes. And I've had a lot of patients say the reason why they have accepted treatment in our office is because they love that relationship. So one thing that you won't hear here, and that I do, and I recommend you all do that, is definitely ask for urgency or timelines before you leave the room. You know, say either, you know, I really would like you to do this soon because, or within the next 2 weeks because, or, you know, definitely within this month because, whether it's disease or they have barely enough bone or whatever it is, because when you have that sense of urgency, it does prevent them from saying, I'll call you back, let me think about it, let me schedule it next year, or whatever it is. So definitely help them with that sense of urgency.
We just saw an example of urgency, by the way. Those of you who signed on because we put an October 31st deadline, you saw urgency. That's exactly the way advertising goes. And one part of advertising is deadlines. And so it's the same thing with this kind of treatment as well. By the way, if it can wait, don't lie. That's not the idea. But also, if there is a sense of urgency because there's an infection, a variable infection, as Danielle said, bone is going to go away, or whatever the problem is, you know, patients would love to have an excuse to put it off. Don't give them that opportunity if, in fact, there's a disease process that's going to hurt them. Yeah. Because that tendency would then be saying, well, it really didn't seem like it was bothering them that much, and then you know what happens. You see them 2 or 3 years later, and what shape are they in then?
Yes. And you will say something like that in the means of, you know, can they wait? Yeah, you know, yes, of course they can wait, but if they wait longer than 30 days, 60 days, we are going to have to do another examination again because the disease may be a little bit worse and we may have to do more root planing, or there may be more bone loss and I may have to do a bone graft or a sinus lift at that time. So at least you're letting them know why not to wait, not so much as, you know, you have to do it like in 7 days or we have to do a sinus lift. It's not that. But you want them to know what happens when people do wait.
I have what I need. Did you have any questions, Joy?
No. I will have some for you, I believe.
Okay.
The PRGF you mentioned.
Yes.
So
we can go over all that.
okay. Sounds good. Thank you.
Good. You're welcome.
Now, I think it's important because Joy brought it up, and Joy, I'm sure you all know, is a staff member of ours. But Joy did bring it up because it is important. Don't let somebody go past a misunderstood word. You know, when you don't understand something, you just blank out. I mean, that's all of you know that we're a Hubbard Management Technology, and in the Hubbard Management Technology, right at the beginning of every book that you read, don't go past a misunderstood word. So it was actually my faux pas to say words that wouldn't be explainable. And if she says PRGF, yeah, we got to make sure we clarify that right away. Patient has to be totally informed and has to have a clear head before they can accept treatment.
Yes.
So anything else that we're going to do today?
Today, no. However, if you guys have any questions in regards to this video or your staff has any questions when they watch us, please email me. We do love to hear your questions and we would be happy to help you with any of that. That's it for this, the doctor presentation. We'll be back again next week for a full treatment plan presentation. And we look forward to hearing from you and look forward to seeing you then. Thanks for joining us tonight. Good night.